because you may be staring at a disaster. You may do a cataract surgery, patient may end up with problems. Okay, I think we'll finish after Dr. Sharmila. So I welcome Dr. Sharmila. Dr. Sharmila is a very senior ophthalmologist. She is actually a senior assistant professor from the AIOC2022, the Regional Institute of Ophthalmology, Chennai. And she's the present editor of Tamil Nadu Journal of Ophthalmology. And she's a very prolific surgeon, well-known teacher, and a postgraduate teacher. And today she is here to share some of the Cornea X files, as the name suggests. So we're going to really look for some very interesting and a very problematic cases in cornea. So from none other than Dr. Sharmila Devi. Please go ahead.
Good morning, everyone. Thank you, sir, for the very kind introduction. My topic is Cornea X files. So it'll be just a case-based scenario, I think we have a packed hall, so it would have been nice if it had been an interactive session, but for want of time, I think we have to rush. So I'll start off with a very common case. I think everyone will be getting a keratitis case for your examination. It can be bacterial, fungal, viral, or acanthamoeba. So what many PGs do is they start off with an ocular examination and they start describing the lesion. So that is not the way to go. You have to do a complete ophthalmic evaluation, and you have to look for ectropion, entropion, meibomitis, and unless you look for it, you will definitely miss a lag of ophthalmos, and many times lag of ophthalmos, nocturnal lag of ophthalmos, all of it is missed because we don't look for it. And any neurotrophic keratitis and evaluation of the tear film is again very important. I think Dr. Rashmi Deshmukh clearly showed you how to evaluate the ocular surface. It's very important to do all of this and do a comprehensive evaluation before you present the case. So this is how you go about it. You should also look at the proptosis and any amount of exposures there, and you should see the forehead. So don't just look at the eye per se, look at the face, look at the forehead, look at the tip of the nose, and your examination should start from the way the patient walks into the clinic. So another common question which is asked in exam is the differentiation between a bacterial keratitis and a fungal keratitis. And on the right, you see a dry, dirty looking ulcer and an elevated epithelial plaque. And here you see a creamy suppurative lesion, and you can see the lid margin. There is some pus pointing, and that is a point of contact with the cornea. I am sure all of you will answer saying that the symptoms are more in case of a bacterial keratitis than signs. And why is it so? Can anyone answer why is it so? I'm not asking my PGs because I've been asking them so many times. So this again is a very common question which is asked, and the common answer given is the symptoms are more, but why? Because Prajna sir has a very nice explanation for it. Bacteria is a very small organism, and the neutrophils attack the bacteria very soon. The inflammatory cascade is set rolling, whereas in fungi is a bigger organism, and it takes some time for the organism to settle down and the inflammation cascade to start off. So that's the reason. And these are different signs of fungal keratitis, and you should be knowing all of it. And what is more specific among these for fungal keratitis? Which one is more specific for fungal keratitis? Feathery edges are the most commonest. It's like a very specific feature for fungal keratitis. And I would also recommend you to read this review article and the MUT1 and MUT2 trial by Dr. Prajna. It's very important to classify the corneal ulcer also into mild, moderate, and severe, because when you classify it as severe corneal ulcer based on the size of the ulcer and the depth of the ulcer, then again your protocol and management protocols might differ, because for a severe corneal ulcer, according to the TST protocol popularized by Dr. Namrata Sharma ma'am, we might have to add some more agents. So it's very important to classify it accordingly. And before you go for exams, you should go through the MUT1 and 2 trial. And what is the conclusion of the MUT1 trial? Septate filamentous fungi are the most commonest causes of fungal keratitis. In North India, it is Aspergillus, and South India, it is Fusarium. And natamycin works very well against them. And orokinosol should never be used as a monotherapy. That is a conclusion given in MUT1 trial. And you should also know about the TST protocol, which is the topical specific and targeted therapy protocol given by Namrata Sharma ma'am. And for severe cases, what they do is addition of an oral orokinosol or ketoconazole, which is not recommended by the MUT2 trial. They say that the oral antifungals are not very effective, but this is the TST protocol. And then also intracameral and intrastromal antifungals. You should also know about PAC-CXL for fungal keratitis and the recent one, the Rose Bengal photodynamic therapy for fusarium keratitis. So these are things that you should refer before you go for examinations. The classification of fungi, again, it's important from a PG point of view. And what is more important is, before septate filamentous fungi were the ones that we read upon mostly, and after the mucor epidemic, even the non-septate filamentous fungi became very popular. Now of interest is this uncertain classification, Pythium insidiosum. So how do you make a diagnosis of Pythium when you put the patient on antifungals and the patient doesn't respond to the antifungal therapy? And then when you see this pinpoint type of infiltrates and tentacular projections and a peripheral gutter, then you think of Pythium keratitis. The treatment is different, so you have to put the patient on linezolid and oral azithromycin for this patient. The case 2, how will you describe this case? So you have a papillary lesion here. You have vessels of different caliber entering into the lesion, and it is involve the limbal stem cells and is straddling the cornea. So it's the diagnosis is very clear-cut. It's ocular surface squamous neoplasia. So you can have different varieties. The morphologically, it can be leukoplakic, gelatinous, papilliform, and pigmented. This pigmented type of OSSN can be differential diagnosis for a corneal melt with iris tissue incarceration or even melanoma. So you should be very careful in evaluating it. And again, you should go do a step-by-step approach and make a note of the vascularity, describe the vessels which are entering into the lesion, look for any keratinization, and ocular surface staining with rose bengal. If you see keratinization and if you see an ocular surface staining with rose bengal which is positive, that is very, very specific for an ocular surface squamous neoplasia. Impression cytology doesn't have much value in the area of anterior segment OCT, but you can do it even for small lesions. Before you interpret an abnormal AS OCT, you should be knowing how a normal AS OCT will look like. And what you see here is a thin hyperreflective tear film, and then you have a hypodense hyporeflective area, which is the epithelium, and then the corneal stroma and the endothelium. So here, what you see is a normal epithelium, which is hyperreflective, and then you have this sudden transition into a hyperreflective and thickened epithelium, which is very, very characteristic of ocular surface squamous neoplasia and anterior segment OCT. Anterior segment OCT, you should also be able to differentiate it from other conditions like conjunctival lymphoma, conjunctival amyloidosis, and conjunctival melanoma, which are all subepithelial. Whereas conjunctival nevus, you'll have lots of cystic spaces here. There's an image from AO, you can refer that. So before, you should also be able to classify the grades of OSS on histopathology because treatment protocols are going to be different for this category, which is where there's a breach of the basement membrane, and up to this, the treatment protocols are different. So what we do, an excision biopsy is not just an excision biopsy which you do for other lesions. So you should follow the no-touch technique, and it's called the Shield 6-step technique, where you delineate the margin of the lesion. On the conjunctiva, it's 4 mm, on the cornea, it is 2 mm, and you do an alcohol keratoepitheliectomy. And the next step is you do a conjunctiva tenoidectomy, a lamellar keratectomy, a lamellar sclerectomy for 0.2 millimeters, and then you do the reverse cryotherapy, which is double freeze-thaw cryotherapy to the posterior conjunctival margin, conjunctival edges and the base, and amniotic membrane grafting to reconstruct. And that's how you draw the diagram, and you can mark the lesion and send it for HPE. So what are the indications for topical chemotherapy? This question is again asked very frequently. So if you have a corneal OSSN with visual axis involvement, if you have more than 6 clock hours limbal involvement, and if you have very small lesions, or if the base or edges are positive on HPE, then those are indications for topical chemotherapy. You should be knowing about the agents which are used for chemotherapy. So this is again given by Santosh Anawar sir, the classification based on histopathology and the treatment protocols. So if you have an invasive type of OSSN with a positive margin, then you have to re-excise. With a positive base, then you have to go for a plaque brachytherapy. Like I told you before, if the visual axis is involved, then we do a pre-op adjuvant chemotherapy. We use mitomycin C in our hospital, but if the patient is affordable, then the patient can go for interferon alpha. This case is a case of severe VKC. I think you can give the answers as well, but for want of time, I'm just running off. So this is a case of severe VKC. So you have the palpebral conjunctiva involvement, the bulbar conjunctiva involvement, and you can see the limbal involvement, limbitis, Horner Trentus dots with a partial limbal stem cell deficiency. So you should be able to document in this manner the number of papillae. So that's how you go about it. And again, allergic eye disease is a spectrum. So it starts in the milder varieties and goes to the severe varieties. So you should be knowing about the different spectrum of the disease and the step-ladder pattern for the management protocols, which starts from mast cell stabilizers and lubricants, topical cyclosporin, topical tacrolimus eye ointment, and it can go up to oral. Some patients, pediatric cases, we use oral corticosteroids and also supratarsal injections of triamcinolone. So this case is, again, a uniocular chemical injury. So what you see here is a limbal stem cell deficiency. So why do you call limbal stem cell deficiency? Because you have loss of corneal clarity, you have vascularization of the cornea, there is pannus over the cornea, and you can see a slimfron here. So it's a uniocular chemical injury, and some cases are bilateral chemical injuries. So this child was a case of uniocular chemical injury, and he had a timely amniotic membrane grafting done for him. So you can see the nice pannus here, and symphlephron here. So what was done for him was a conjunctival limbal autograft and a SLET, a simple limbal epithelial transplant. The limbal stem cells were taken from the other eye because it's a uniocular injury. So it's an auto SLET. If it is a bilateral chemical injury, then we have to take the limbal stem cells from a cadaveric donor, and then you have to do it up with immunosuppression. So pre-operatively, we have to follow the immunosuppression, and then post-op, again, the immunosuppression has to be continued. That's the limbal dermoid. Limbal dermoids can be kept as a spotter. So you have to really grade the limbal dermoid properly. The amount of astigmatism has to be calculated. You can do an ASOCT and document the extent and the depth of involvement, whether it's 100 microns or more than that. And based on that, your treatment protocols vary, whether you just want to do an amniotic membrane grafting for it or you want to do a lamellar patch graft for it. So this case was a golden hour syndrome for whom we did a lamellar patch graft. This is a case of peripheral ulcerative keratitis, and as we talk about PUK, we have the PUK expert walking in here. So we have an area of thinning here, and we have a stromal melting here. This is a lamellar patch graft done for the case of PUK. So the first investigation that you should do for a case of PUK is a smear. We have to rule out infectious causes. And again, we have to do a complete workup. Systemic collagen vascular disorders have to be ruled out, and 34% of the cases can be rheumatoid arthritis. And what is more specific for rheumatoid arthritis is not just RA factor. We have anti-CCP, so that should be done for these cases. And this is, again, is a very common question which is asked by examiners. Why is it more common in the periphery? You have to, I think you can take a picture of this, a photo of this slide. This is why it's very important in the periphery. The IgM and Langerhans cells and antigen-presenting cells are all very high in the periphery. So again, if there is no systemic cause and it's Murins is just a diagnosis of exclusion. So if you rule out all of the other causes, then it can be Murins. You should be knowing about the Watson's criteria for Murins ulcer, the bilateral aggressive Murins, the bilateral indolent Murins ulcer in old age. So these talks are there in YouTube. That's what Arup sir said. It will be there in, I think, editor proceedings. So I think instead of taking pictures, you can also see there. So what are the indications for immunosuppression and PUK? So we have PUK unresponsive to aggressive conventional medical and surgical therapy. Progressive bilateral PUK, one-eyed patient, or lethal systemic vasculitic syndromes or corneal perforations. Then we can start the patient on immunosuppressants. And you should be knowing about the immunosuppressants used for these cases, and you can refer that paper for immunosuppression in PUK. So these are the treatment options available. You can do an amniotic membrane grafting. You can do a lamellar patch graft. First, you start off with a conjunctival resection. And immunosuppression is very, very important, and I would recommend you to read that paper on immunosuppression by the LVPI group. These are all corneal perforations of different etiologies, so it can be an intrinsic pathology or an extrinsic pathology. This patient was a firecracker injury. would have gone for corneal decompensation if we hadn't done an intervention for him. So what are the treatment options available for corneal perforations? You can do a tissue adhesive with cyanoacrylate glue. You can do a multi-layered amniotic membrane grafting. You can do a patch graft. Or you can do a T-nonce patch, which is the new kid on the block. So we've done a tuck and T-nonce patch for this case, and this patient had a good visual acuity. He had a cataract, and then he was later operated for it. So this is a technique which is popularized by Namrata Sharma ma'am and Vajpayee, and this overlay sutures was given by Dr. Sayan Basu. Again, dystrophies also will be kept as exam cases. You should be knowing about the different types of stromal dystrophies, how to differentiate one from the other. So that is a granular, you have the breadcrumb appearance. And how do you differentiate it from a macular? Because the intervening spaces are clear, whereas here it is, it's all hazy and it extends up to the mid-periphery. And you should be knowing about this mnemonic. Marilyn Monroe always gets her money in LSCT. Why money instead of men? Because some examiners can be conservative. So you can just put it as money. So you should definitely know this mnemonic and go by it. That again is a spotter that can be kept as a spotter. It's a blood staining of cornea. Post firecracker injury, the patient went for a blood staining of cornea because the intraocular pressure was not controlled well. And so this patient was taken for a DSEC, or you can even take it for an OKP. The last slide. So that is a case of hydrops. You can see the DM tear on the ASOCT and the aqueous seeping into it and causing a hazy cornea. So what was done for this case was pneumodescemetopexy with compression sutures. I think ectatic disorders are covered in a separate session, so I'll wind up with that. Thank you.